This video discusses the essential steps for the management of a child with severe malnutrition. Severe acute malnutrition is defined by the presence of edema, severe wasting, or a mid-upper arm circumference below 115 millimeters. Children with severe wasting do not always require hospitalization unless they have a serious illness. The WHO growth charts provide interpretations of Z-scores for classification of nutritional status, including weight for age, and weight for height. The chart also interprets BMI for age to classify obesity, overweight, normal, thin, and severely thin status. Risk factors for malnutrition include prematurity, low birth weight, early cessation of breastfeeding, serious infections, and chronic diseases. Socioeconomic factors like teenage mothers, large families, and poor sanitation also contribute. Initial assessment involves taking a thorough history, including details about food and fluid intake, diet before illness, breastfeeding, diarrhea, vomiting, appetite loss, and family circumstances. Exposure to diseases like TB and measles and HIV status are also noted. The physical exam looks for signs of shock, dehydration, severe palmar pallor, and bilateral pitting edema. Clinicians should also look for eye signs of vitamin A deficiency, signs of infection, HIV infection, hypothermia, mouth ulcers, and skin changes indicative of kwashiorkor. Organizing care begins with an appetite test, using ready-to-use therapeutic food. Those with an appetite are treated as outpatients. Those who fail or have severe edema or general danger signs are treated as inpatients. Severely malnourished children must be kept warm and monitored closely. Management of severe malnutrition includes addressing corneal ulceration with vitamin A, antibiotics, and eye drops. The overall treatment is a 10-step plan divided into 2 phases: initial stabilization and rehabilitation. The WHO timeframe for complicated severe malnutrition shows the 10 steps. Stabilization, occurring in the first week, focuses on critical immediate issues. Rehabilitation, starting in week 2, concentrates on growth and follow-up preparation. Step 1 is managing hypoglycemia, which often co-occurs with hypothermia and infection. Frequent feeding is key. A conscious child with low blood glucose gets oral glucose or sucrose, followed by frequent F75 milk feeds and oral amoxicillin. Step 2 is managing hypothermia. If the temperature is low, immediately feed or start rehydration. Rewarm the child with blankets or skin-to-skin contact and administer antibiotics. Step 3 focuses on managing dehydration. IV rehydration is only used for shock and must be infused slowly. Standard oral rehydration salts are unsuitable due to high sodium and low potassium. Use special rehydration solution for malnutrition, Risomal, instead. For children with watery diarrhea, assume dehydration. Give Risomal every 30 minutes, followed by an hourly dose for 4 to 10 hours, replacing some doses with F75 milk feeds. Monitor vital signs and clinical improvements closely. Not all severely malnourished children will show rehydration changes easily. Persistent rapid breathing and pulse may indicate coexisting infection or overhydration. Signs of excess fluid include increasing respiratory rate, pulse rate, edema, and puffy eyelids. Stop fluids immediately if these signs occur. Step 4 addresses electrolyte imbalances. Severely malnourished children have total body sodium excess, despite potentially low plasma levels. Treat with extra potassium and magnesium, and use low-sodium rehydration fluid like Risomal. Prepare food without added salt. Step 5 is to manage infections. Since usual signs of infection are often absent, routinely give broad-spectrum antibiotics and the measles vaccine upon admission. Metronidazole may also be given to aid intestinal repair and reduce systemic infection risk. Broad-spectrum antibiotic choice depends on complications. If the child has no complications, use cotrimoxazole. If the child is severely ill or has complications, start with ampicillin and gentamicin. If the child fails to improve after 48 hours, add chloramphenicol. Step 6 is managing micronutrients. All severely malnourished children have vitamin and mineral deficiencies. Do not give iron initially. Provide a vitamin A dose on day 1, based on age. Give daily supplements of multivitamins, folic acid, zinc, and copper for at least 2 weeks, adding iron only when weight gain begins. Step 7 is cautious feeding during the stabilization phase. Start feeding as soon as possible, with small, frequent, low osmolarity, and low lactose feeds. Aim for 100 kcal and 1 to 1.5 grams of protein per kilogram per day, and 130 milliliters of fluid per kilogram per day. Milk-based formulas like Starter F75 are satisfactory. Give feeds from a cup or by spoon, dropper, or syringe for weak children. If intake doesn't reach 80 kilocalories per kilogram per day, give the remaining feed by NG tube, but do not exceed 100 kilocalories per kilogram per day. Step 8 is catch-up growth during the rehabilitation phase. which requires a vigorous feeding approach to achieve rapid weight gain. Use F100, which has higher energy and protein, or comparable modified porridges or family foods. Begin this phase once the child's appetite returns. To transition from F75 to F100, replace the starter with the same amount of F100 for 48 hours. Then, gradually increase feed volume. Monitor for signs of heart failure during this transition, like increased respiratory and pulse rates, and reduce the volume if these signs appear. Assess weight gain to monitor recovery. Good gain is more than 10 grams per kilogram per day. Moderate gain is 5 to 10 grams per kilogram per day, requiring a check on intake targets or infections. Poor gain, less than 5 grams per kilogram per day, necessitates a full reassessment. Step 9 is sensory stimulation to address delayed mental and behavioral development. Provide tender, loving care, a stimulating environment, structured play therapy, and physical activity as soon as the child is well enough. Encourage maternal involvement in care. Step 10 is preparing for follow-up. A child is considered recovered when they reach 90% weight for length. Advise the mother on frequent feeding with nutrient-dense foods and continuing sensory stimulation at home. Schedule regular follow-up checks, booster immunizations, and ensure vitamin A is given every 6 months. This video utilized the Namibia Standard Treatment Guidelines, the WHO Pocketbook of Hospital Care for Children, and other lecture materials as references. Thank you for watching this video on the management of a child with severe malnutrition.